次に、ハーバード大学 T.H チェン公衆衛生大学院武見国際保健プログラム主任教授のマイケル・ライシュ先生からご講演をいただきます。先生は40年以上にわたり日本の医療政策の研究に携わり、日本の国際保健の推進と公衆衛生の発展に大きく寄与されてまいりました。その功績をたたえるために2015年4月、春の外国人叙勲で旭日中綬章を受章されております。本日はユニバーサルヘルスカバレッジを目指して一歩一歩の進歩と題しましてご講演をいただきます。それではライシュ先生、よろしくお願いいたします。Please。
ハーバード大学のマイケル・ライシュでよろしくお願いいたします。今日は国際シンポジウムですので、私はこの講演を英語で話をさせていただきます。So it's a great pleasure for me to be here today. In recognition of the namesake of the symposium with Dr. Taro Takemi and the Takemi program, I wanted to just ask the Takemi fellows in the audience to stand. So these are in recognition. Over the last 35 years, as was mentioned, we've had 271 fellows from over 50 countries. I would urge you, if you have the opportunity, to talk to them. They're a marvelous group. And they really embody, in their own personal studies and their efforts, the principles that were discussed by Sir Michael. In contrast, I am not Sir Michael, I'm just plain Michael. But actually, the fellows are working both on the social determinants of health as well as what I'm going to speak about in my talk. So our talks are actually complementary. I'm going to focus on the healthcare system and think about the question, how do we move forward? And fundamentally, it's concerned with the same kinds of values. Questions of inequality, questions of inequity, questions of fairness. But I'll focus on the questions that happen within healthcare policy and within the healthcare system, usually under the control of the Ministry of Health and within reach of physicians. So this is the structure of my presentation. I'm going to talk a little bit about UHC and the policy agenda, then discuss some of the challenges of defining and measuring UHC. Thirdly, we'll go to the experiences of two countries that I happen to know reasonably well, and then end with a few brief lessons. So UHC is on the policy agenda, both for the world and for Japan. This is a list of some of the many examples of how the idea of universal health coverage at the national level has been accepted around the world. The WHO, the World Health Organization, has resolutions. I'm going to particularly talk about an event that happened in Tokyo just a little while ago in December that I had the honor and pleasure to participate in. So this is a picture that I took with my telephone in December, and it shows the leaders of many of the global health organizations around the world who gathered in Tokyo to declare their support for UHC. It includes the Prime Minister of Japan, it includes the head of the United Nations, the Secretary General, the head of the World Bank, the head of the Global Fund. It includes the head of the Japan Medical Association, World Medical Association. It includes some other notable people who are in this audience, including Keizo Takumi. Bill Gates himself appeared on a screen to say, "I support UHC." They have not been so clearly supportive in the past. Japan's finance minister, Minister Aso, wrote an article in The Lancet talking about how he personally and the finance ministry in Japan has been important in moving Japan towards UHC, and how the same thing has to happen in other countries. Dr. Yokokura gave a statement about both the World Medical Association and the Japan Medical Association supporting UHC, and again, this picture was taken with my phone. Aren't we lucky to have telephones that take pictures? Of the new Director General of the World Health Organization and Dr. Yokokura saying, "Let's work together to advance UHC." What's really interesting about these series of photos and this series of events is that Japan now has become the major country around the world supporting UHC and pushing the global agenda forward. This is a remarkable achievement. So it brings us to the question, well, what is UHC and how do you get there? So this is the definition provided by the World Health Organization. All people have access to the health services they need without the risk of financial hardship when paying for them. As Sir Michael said in the talk before me, just because people have access doesn't mean necessarily that they will use them or benefit from them because of social context and social factors. But this says they should have access. So this is a slightly redrawn cube that was devised by the World Health Organization, where they said, this is UHC. How many people have seen this cube before? The WHO has done a marvelous job of promoting this diagram to think about UHC. It says, think about it on 3 dimensions. Population, who has coverage, services, which services are covered, and costs covered, how much are pooled resources used to pay for those services. These are all averages, presumably for a country. Several years ago, some colleagues of mine at Harvard and I were teaching a course that we have taught for 20 years about improving health system performance, called the flagship course. And we said, there's a problem with this figure. It's misleading. This is not the way countries are. Countries are not averages. And one of my colleagues, who has since passed away, said it should be a step pyramid. You have to disaggregate the averages by different social groups. This is by income group. Again, making the point Sir Michael made, but a different perspective. Different income groups have different services covered and different proportion of costs covered. thinking about averages is not very helpful. So we came up with this step pyramid. It's published in a journal that I run called Health Systems and Reform. And I'm happy to give anyone a copy if they're interested. The problem is the WHO cube does not tell us what to do next. Should we expand population? If so, which population? Should we expand services? If so, which services? Should we expand costs covered? If so, which costs, how much? So a policymaker has hard choices presented. The cube does not help them make those choices. There's another recent effort done by the World Health Organization and the World Bank to say, let's measure how all countries in the world are doing in moving towards UHC. So they created an index. This was presented at the meeting in December here in Tokyo. They created what's called a mash-up index. That's a technical word that means basically you throw things together without a good theory or rationale so that you can create a number, so that you can measure. It's a composite. It gives you a single number. And the purpose is international comparison of countries for their artificially measured progress in moving towards UHC. I'm not going to show you the results of that study, but this index has the same problem. It doesn't tell you what to do next. It uses population averages. It uses selected services for a couple of different, in some ways, arbitrarily selected services. It doesn't provide countries with practical guidance about what to do next. And my point here is that measurement for comparison is not the same as helping policymakers make decisions about what to do next. This is another photo with my phone. It's wandering in the desert in Southern California, looking for the path to UHC. This is really what policymakers are confronted with. Where do I go? What do I do next? How do I transform the principles of social justice and ethics into concrete technical programs that will be politically acceptable and move forward towards the promised land of UHC? So these are difficult questions. I said, let's look at the experiences of two countries. What did they actually do? Let's start with Japan. It's very interesting. So Japan started in 1905 with some public sector employees. 1927, manual workers. 1939, office workers. In the 1930s, they started community-based health insurance programs to cover other people. This is all expansions of populations covered, reaching full mandatory coverage in 1961. This is a very nice graph and a very nice figure. It shows over time. Underlying this are both political and ethical factors driving the decisions. What about services covered? Japan has a single fee schedule, which is similar to some other countries in East Asia. It was introduced in 1927 for some people then covered by health insurance. It focused on primary care and prescription medicines. In 1958, this was made mandatory for the other large group of insurance programs in communities. The result is a single benefit package, a single reimbursement rate, and gradual expansion of services covered over time, managed by the government, with input of stakeholders. What about pooled resources? In Japan, what was covered? It was adjusted and expanded over time. Originally in the 1920s up to the 1950s, different plans had very different co-payment rates. In short, a structural unfairness. In the 1960s and 70s, those rates were changed over time to reduce the benefits for private employees and raise the benefits for others. There was an introduction of no co-payment for elderly, but later raised. In 1973, there was catastrophic coverage introduced. This is gradual improvement and reduction in inequities over time. There still are inequities. The premiums for different plans in Japan are different depending on which group you belong to. Okay, now let's look at Mexico. Mexico also had gradual expansion over time of population groups covered. 1943, social insurance was started for private sector. 1959, they had social insurance for public employees. In 2003, a new system was introduced for people not covered. It's interesting that even today, there's still approximately 13% uncovered in Mexico, although Mexico has declared that they have achieved UHC. This is a plaque, again, taken with my telephone, in the Ministry of Health in Mexico saying, "Banzai, we have achieved UHC in 2012. Mexico has also increased the services covered. And this is for the program that was introduced in 2003. On the left is the general packages of services. On the right is the catastrophic services. And you can see the catastrophic services has increased the number of diseases covered and the particular diseases covered over time. And finally, the pooled resources has also expanded in Mexico over time. Although it's worth noting, for this program, Seguro Popular, it was introduced with the idea that it would have premiums paid by different population groups, with the premiums adjusted according to income. Everyone who joins the plan self-declares as being poor, so 99.5% of the members pay zero premium. This has implications both for fairness as well as for financial sustainability. And in a course that I teach in Mexico in January every year, we had a group of students working with this plan on the question of how to introduce premiums in a way that is fair and politically feasible. Let's just say it's difficult. The point here is that there are inequities that persist in Mexico as well that have to do with social, structural inequalities and the way in which programs are designed and set up. So this brings me to a few lessons that I would like to leave you with. So the first is moving towards UHC is an iterative, step-by-step process. There is no simple formula that every country can use. And it occurs over time. It is not easy. The second, and if you look at the experience in Japan and the experience in Mexico, it's a process that occurs over decades, 50 years or 100 years. The second point is to stop thinking about UHC as an end point, some place that you arrive after wandering in the desert, some kind of promised land. Think about UHC as a process. Universal coverage with health insurance is just one point in that process. Japan achieved that in 1961, but there were still many problems of unfairness, many problems of services, costs that had to be adjusted over time. And those problems still remain. In some sense, we will never achieve UHC. It's the process that counts. And thirdly, each country has to find its own path in the desert in seeking to improve the performance of its health system, in seeking to improve the fairness among populations, the profound problems of fairness among different services, and the problems of how to reduce the costs that people pay and that sometimes drive families into poverty. Those problems still exist in Japan. Those problems still exist in Mexico. Let me just end on the note that you'll notice that I did not say one word about the United States. That was intentional. In some ways, the United States has the most serious problems in moving towards UHC, and it would require, in a sense, a talk of its own. One of my messages here is that I think that there are lessons to be learned for the world about how Japan has moved forward towards UHC, how Japan has managed the process, the ethical and political challenges and technical challenges of moving forward during the 20th century in producing a healthcare system that the Japanese people should justifiably be proud of in terms of the population covered, the services provided, and the costs that are shared. Thank you very much.
ライシュ先生、誠にありがとうございました。長い国際経験、そして日本の UHC に関する深い理解に基づきまして、さまざまな道をご教示いただきました。感謝申し上げます。